Respected audience, Assalamu alaikum. I am Professor Shamsudjaman, Professor of Pathology. I welcome all in today's third lecture on systemic pathology. Today, day one of diseases of stomach. Today's topic is peptic ulcer. Day one of diseases of stomach. Today's topic is peptic ulcer. First, going to discuss about peptic ulcer. We have to recapitulate what is ulcer. Ulcer is the discontinuation of surface epithelium due to sloughing out of inflammatory necrotic tissue. Dear audience, if this is the surface epithelium of the skin, if we cut it with a blade or knife, it is not ulcer. Although there is discontinuity of the surface epithelium following cutting, it is not ulcer. It is cut injury. If there is inflammation here, following inflammation, if there is necrosis, and if there is sloughing out of this necrotic tissue, there will be discontinuity of the surface epithelium, and this is known as ulcer. So ulcer is the discontinuity of surface epithelium due to sloughing out of inflammatory necrotic tissue. Now come to peptic ulcer. What do we mean by peptic ulcer? Chronic, usually solitary lesion at any part of GI tract. Chronic, usually solitary lesion at any part of gastrointestinal tract exposed to acid pepsin digestion. Is known as peptic ulcer. Dear audience, peptic ulcer is a chronic lesion. It is usually solitary lesion. It may occur at any part of GI tract exposed to acid pepsin digestion. Suppose this is esophagus, this is the stomach, this is duodenum, and this is the GI tract. So, any chronic lesion at any part of the GI tract exposed to acid pepsin digestion is known as peptic ulcer. Dear audience, there are many ulcers that occur in the GI tract. Among these ulcers, the ulcer which is due to acid pepsin digestion is known as peptic ulcer. The ulcers other than the acid peptic digestion in the GI tract is not peptic ulcer. So, the lesion at any part of the GI tract exposed to acid pepsin digestion is known as peptic ulcer. Now come to what are the different sites of peptic ulcer. Sites of peptic ulcer. First part of duodenum, antrum of the stomach, lower end of esophagus, gastrointestinal stroma, gastrointestinal stroma, duodenum, jejunum, and ileum simultaneously. Simultaneously, there is peptic ulcer in duodenum, jejunum, and ileum. It usually occurs in Zollinger-Ellison syndrome. As in Zollinger-Ellison syndrome. It may occur in Meckel's diverticulum if the Meckel's diverticulum contains ectopic gastric mucosa. Meckel's diverticulum containing ectopic gastric mucosa. Duoden's first part of duodenum and top of the stomach, lower end of esophagus, gastrointestinal stroma, duodenum, jejunum, and ileum, as in Zollinger-Ellison syndrome, Meckel's diverticulum containing ectopic gastric mucosa. Duoden's lower end of esophagus, there may be peptic ulcer when there is columnar metaplasia in the lower end of esophagus due to repeated gastric reflux in the lower end of esophagus. If there is repeated gastric reflux in the lower end of esophagus, stratified squamous of the lower end of esophagus is replaced by gastric columnar or intestinal-like columnar, and it is known as Barrett mucosa or Barrett esophagus. So, peptic ulcer occurs in the Barrett's esophagus or in the Barrett's mucosa. If anybody suffers from Zollinger-Ellison syndrome, there is chance of peptic ulcer in the duodenum, in the jejunum, and also in the ileum simultaneously. Now come to Zollinger-Ellison syndrome. Dear audience, this syndrome composed of peptic ulcer disease, composed of peptic ulcer disease, gastric hypersecretion, and tumor of islet of pancreas that secretes gastrin. Tumor of islets of pancreas that secretes gastrin. And this gastrin secreting tumor in the pancreas is known as gastrinoma. So the name of tumor is gastrinoma. And this tumor secretes gastrin. If there is elaboration of gastrin from this gastrin secreting tumor of the pancreas, this gastrin acts upon the gastric glands and secretion of hydrochloric acid. This hydrochloric acid acts upon the duodenum, acts upon the jejunum, acts upon the ileum, and leads to peptic ulcers in the duodenum, jejunum, and ileum simultaneously. So it is in Zollinger-Ellison syndrome. Dear audience, now come to gastrointestinal stroma. Suppose this is stomach, and if there is gastric outlet obstruction, in this case, operation is done. That operation is known as gastroenterostomy. And if there is gastroenterostomy operation, there is a stoma, and this stoma is exposed to acid pepsin. So there is chance of peptic ulcers in the gastroenterostomy stoma. Dear audience, I have told you Meckel's diverticulum containing ectopic gastric mucosa. If Meckel's diverticulum is present, but there is no gastric mucosa, there will be no peptic ulcer. If Meckel's diverticulum present, and if there is ectopic gastric mucosa in the Meckel's diverticulum, there will be peptic ulcer. Respected audience, now come to gastric ulcer. Gastric ulcer is the peptic ulcer in the stomach. Peptic ulcer in the stomach is the gastric ulcer. Now come to pathogenesis of gastric ulcer. Again we recapitulate. It is chronic swelling relation at any part of GI tract exposed to aggressive action of acid pepsin digestion. If there is local defect in the stomach due to acid pepsin digestion, this is known as gastric ulcer. Come to pathogenesis of gastric ulcer. Dear audience, we know no acid, no ulcer. No hydrochloric acid, no ulcer. We know no acid, no ulcer. What it means, if gastrointestinal mucosa is not exposed to hydrochloric acid, there will be no peptic ulcer. Dear audience, gastric ulcer is associated with normochlorhydria, hypochlorhydria, or hyperchlorhydria. But gastric ulcer or peptic ulcer is not associated with achlorhydria. It means no acid, no ulcer. Peptic ulcer is associated with normochlorhydria, associated with hypochlorhydria, and associated with hyperchlorhydria. Normochlorhydria means normal gastric acidity, hypochlorhydria means decreased gastric acidity, hyperchlorhydria means increased gastric acidity. In all cases there is acid, either acidity is normal or decreased or increased, but there is acidity. As there is acidity, it is associated with peptic ulcer. But peptic ulcer is not associated with achlorhydria. Achlorhydria means there is no gastric acidity. If there is no gastric acidity, there will be no peptic ulcer. So no acid, no ulcer. Dear audience, imbalance between the aggressive action of acid pepsin and defense of gastrointestinal mucosa is associated with peptic ulcer, is associated with gastric ulcer. Imbalance between aggressive action of acid pepsin and defense of gastrointestinal mucosa. imbalance between aggressive action of acid pepsin and defense of gastrointestinal mucosa is associated with peptic ulcer. Is associated with peptic ulcer, that is associated with gastric ulcer. Dear students, now come to defense of gastrointestinal mucosa. Defense of gastrointestinal mucosa. Suppose this is the stomach. This is the wall of the stomach. These are the lining epithelium of the stomach, columnar epithelium. First defense is the tight junction between the lining epithelium. Tight junction. Tight junction between lining epithelium. Dear audience, if this is the stomach wall and if this is the lining epithelium, column epithelium, this is the tight junction between the epithelium. This tight junction between the epithelium is associated with the defense of gastric mucosa. Number 2, mucin secreted by gastric glands. This mucin provides soothing effect on the surface of the lining epithelium. This mucin provides soothing effect on the lining epithelium. This mucin is associated with defense of gastrointestinal mucosa. Another one is mucosal vascularity. So, tight junction between lining epithelium, mucin secreted by gastric glands, mucosal vascularity associated with the defense of gastrointestinal mucosa. Dear audience, now come to how this defense of gastrointestinal mucosa is decreased. I mean, what are the causes of decreased gastrointestinal mucosal defense? Causes of decreased gastrointestinal mucosal defense. How the defense is decreased? What are the causes? One is gastritis. Dear audience, we are talking about gastric ulcer. If there is gastritis, that is inflammation of gastric mucosa, is known as gastritis. If anybody suffers from gastritis due to inflammation in the gastric mucosa, there will be decreased mucosal defense. Prolonged exposure to unbuffered aspirin. Prolonged exposure to unbuffered aspirin. This unbuffered aspirin irritates on the gastric mucosa and causes decreased gastrointestinal mucosal defense. Decreased mucosal defense of the stomach. Alcoholism. Alcoholism is associated with decreased defense. Tobacco abuse is associated with decreased defense of the gastric mucosa. LS8, non-steroidal anti-inflammatory drug. Non-steroidal anti-inflammatory drug is associated with diminished gastric mucosal defense. Another one is Campylobacter pylori infection. Campylobacter pylori infection. This Campylobacter pylori infection is associated with decreased mucosal defense of stomach. So, gastritis, prolonged exposure to uncovered aspirin, alcoholism, tobacco abuse, non-steroidal anti-inflammatory drugs, Campylobacter pylori infections are associated with decreased defense of gastric mucosa. Now come to role of Campylobacter pylori in gastric ulcer. This bacteria splits urea and produces hydrogen ion and thereby increases gastric acidity. I have told you, no acid, no ulcer. This Campylobacter acts upon the urea of the gastric juice and splits the urea and formation of hydrogen ion. And this hydrogen ion is associated with increased gastric acidity. It splits of gastric secretion and formation of hydrogen ion, and this hydrogen ion increases gastric acidity. Again, this Campylobacter pylori reacts with the mucin and destroys it. So the soothing effect on the lining epithelium by mucin is diminished. It reacts with mucin and destroys it. Thereby, the soothing effect of mucin on the lining epithelium is lost. Again, the production of hydrogen ion, it increases gastric acidity. This Campylobacter pylori reacts with the mucin and destroys the mucin. As the mucin is destroyed, the soothing effect of mucin on the lining epithelium is diminished. Here it is. So, the imbalance between the defense of gastric mucosa and aggressive action of acid pepsin is associated with gastric ulcer. If there is decreased defense of mucus of the stomach, there will be gastric ulcer. So, decreased mucosal defense is associated with imbalance between aggressive action of acid pepsin and mucosal defense. So, decreased mucosal defense is associated with imbalance between aggressive action of acid pepsin and mucosal defense. So, thereby gastric ulcer. Gastric ulcer. Dear audience, if anyone suffers from gastric ulcer, what will be the morphology of gastric ulcer? Now come to morphology of gastric ulcer. Suppose this is esophagus and this is stomach, and this is lesser curvature, this is lesser curvature, this is the greater curvature. First come to cross examination of gastric ulcer. Cross examination reveals round to oval ulcer. Ulcer is usually situated along the lesser curvature. Ulcer usually along the lesser curvature. Ulcer usually single in number. The size of ulcer usually less than 4 cm diameter. Usually less than 4 cm diameter. The margin of ulcer is punched out shape. The floor or the base of ulcer is clean. Why the base or floor of ulcer is clean? It is due to gastric hydrochloric acid. So these are the characteristics of ulcer on cross examination. So ulcer is usually single. It is usually situated along the lesser curvature. Size is usually less than 4 cm, and the margin is very sharp and looks like punched out, and the floor is clean due to hydrochloric acid. Dear audience, now come to histopathology of gastric ulcer. Histopathology reveals 4 distinct zones. Histopathology reveals 4 distinct zones. From inside to outside, inside to outside, the zones are zone of necrosis, zone of inflammation, zone of granulation tissue, and zone of scab. Zone of necrosis, zone of inflammation, zone of granulation tissue, zone of scab. If we see the ulcer from inside to outside. Dear audience, suppose this is the histopathology. First, we will get zone of necrosis. Then we will get zone of inflammation. There will be a clinical cell infiltration. This is zone of necrosis. Zone of necrosis. This is zone of inflammation. Then we will get zone of granulation tissue. We know granulation tissue is a newly formed mesenchymal tissue composed of proliferating fibroblasts, newly formed capillaries, ground substance, and a few chronic inflammatory cells. These are the component parts of the granulation tissue. This is the granulation tissue. Then we will get fibrosis that leads to scar formation. So this is the zone of scar. This is the histopathology of gastric ulcer. From inside to outside, zone of necrosis, zone of inflammation, zone of granulation tissue, zone of scar. Dear audience, now come to if anybody suffers from gastric ulcer, what may be the complications? Complications of gastric ulcer. Immediate complications. Immediate complications like bleeding from ulcer. If this is the esophagus, if this is the stomach, if ulcer is here, and if this ulcer bleeds, the bleeding in the form of hematemesis, in the form of melena. So in the form of hematemesis or in the form of melena. So bleeding in the form of hematemesis or in the form of melena. There may be perforation. Another complication of gastric ulcer is perforation. There will be perforation. These are the immediate complications. Now come to late complications. Late complications may be gastric outlet obstruction, gastric outlet obstruction. There may be teapot deformity, there may be hourglass contracture, hourglass contracture, there may be gastric carcinoma. So, immediate complications, bleeding in the form of hematemesis, in the form of melena, perforation. Late complication, gastric outlet obstruction, teapot deformity, hourglass contracture, and gastric carcinoma. Dear audience, if this is the esophagus and this is the stomach like this, if there is ulcer is here and it is chronic one, you know chronic ulceration is associated with chronic inflammation, and chronic inflammation is associated with fibrosis. And due to fibrosis, there will be contraction, and due to contraction, there will be chance of development of gastric outlet obstruction. So, as it is chronic inflammation in the chronic ulcer, it is associated with fibrosis. Due to fibrosis, there will be contraction, and this contraction is associated with gastric outlet obstruction. Now come to teapot deformity. Dear audience, suppose this is esophagus, this is the stomach, and this is the ulceration here. You know, gastric ulcer is chronic one. It is associated with fibrosis due to chronic inflammation. As there is fibrosis, there will be contraction. Following contraction, the stomach looks like this. There is contraction. This stomach may looks like this. If you think this is a handle, it looks like teapot. If you think this is the handle of the teapot, it looks like teapot. This is teapot deformity in gastric ulcer. So these are the complications of gastric ulcer. Dear audience, gastric ulcer may be benign gastric ulcer and gastric ulcer may be malignant gastric ulcer. How can we differentiate benign gastric ulcer from malignant gastric ulcer? Now come to differences between benign gastric ulcer and malignant gastric ulcer. Benign gastric ulcer and malignant gastric ulcer. Age of occurrence. Benign gastric ulcer usually occurs in middle age. In middle age. But malignant ulcer usually in older age. Site of ulcer. Benign ulcer usually along the lesser carpuscle. Along lesser carpuscle of stomach. Malignant ulcer usually along the greater carpuscle of stomach. Usually along greater curvature of stomach. Size of ulcer, benign usually less than 4 cm diameter, malignant usually more than 4 cm diameter. Number of ulcer, benign usually solitary, usually single or solitary, but malignant usually multiple. Margin of ulcer. The margin of benign gastric ulcer is clean and it is punched out appearance. Clean. punched out appearance. But the margin of malignant ulcer is irregular but the margin of malignant ulcer is irregular. Why irregular ulcer margin in malignant ulcer? Dear audience, you know malignant cells proliferate rapidly. Due to rapid proliferation of malignant cells, the margin of ulcer is irregular. Base of ulcer. Base of ulcer in case of benign gastric ulcer is clean. It is clean due to hydrochloric acid, but the base of malignant ulcer is dirty. Why dirty base of malignant ulcer? Dear audience, you know carcinoma is associated with necrosis. As there is necrosis, in case of malignant ulcer, there will be dirty base of the ulcer. Histopathology. Histopathology reveals 4 distinct zones in benign ulcer: zone of necrosis, zone of inflammation, zone of dilation tissue, and zone of scar. 4 distinct zones. But malignant ulcer histopathologically reveals anaplastic cells in the form of adenocarcinoma. Anaplastic cells in the form of adenocarcinoma. Anaplastic cells in the form of adenocarcinoma. So these are the differences between benign gastric ulcer and malignant gastric ulcer. Age usually middle-age, old age, site usually along lesser curvature, along greater curvature, size usually less than 4 cm, more than 4 cm. Number of ulcer usually solitary but multiple in malignant one. Margin clean and punched out appearance, irregular margin in malignant ulcer. Base of ulcer clean but dirty base in malignant ulcer. Histopathology reveals 4 distinct zones in benign ulcer, but anaplastic cells is revealed in malignant ulcer in the form of adenocarcinoma. Dear audience, I have told you today about the peptic ulcer. I have told you peptic ulcer is the chronic, usually solid lesion at any part of GI tract exposed to acid pepsin digestion. I have told you no acid, no ulcer. I have told you what are the different sites of peptic ulcer. First part of duodenum, gastric antrum, lower end of esophagus, in Barrett esophagus, gastroenterostomy, stoma, duodenum, jejunum, ileum in case of Zollinger's Ellison syndrome, Meckel's diverticulum containing gastric mucosa as ectopic tissue. I have told you Zollinger-Ellison syndrome composed of gastric hypersecretion, peptic ulcer diseases, and tumors in the islets of pancreas that secretes gastrin. The tumor is known as gastrinoma. I have told you pathogenesis of gastric ulcer, imbalance between the defense of gastrointestinal mucosa and aggressive action of acid pepsin. I have told you the defense of gastrointestinal mucosa is maintained by secretion of mucin, maintained by tight junction of the lining epithelium, maintained by mucosal vascularity. And this defense may be decreased following gastritis, prolonged use of unbuffered gastrin, alcoholism, tobacco abuse, Campylobacter, pylori infection, non-steroidal anti-inflammatory drug use. Campylobacter pylori splits urea of the gastric secretion and production of hydrogen ion. This hydrogen ion increases gastric acidity. Dear audience, I have told you the morphology of the gastric ulcer, cross-examination and histopathological findings, and I have told you what are the complications of gastric ulcer. Lastly, I have told you differences between benign and malignant gastric ulcers. Today, up to this, thanks all.